The goal of this presentation is to explain the 2x4 pathology recognition checklist, which should be used in daily musculoskeletal ultrasound clinical practice to recognise and interpret pathology. Using this checklist will ensure that you read and double-check pathology in a critical and qualitative way, with, as a result, lowering the risk of false positives and false negatives. Using the 2x4 pathology recognition checklist can only be successful if you have applied the 3x4 scanning quality checklist in a correct way during an earlier stage. The checklist has two parts, a structural part and an interpretation part. First, let's focus on the four elements of the 2x4 pathology recognition checklist structural part. The shape or form of an anatomical structure is important. The way it looks will tell you a lot about the current state of the anatomical tissue. When looking for shape changes, start at the bottom of the ultrasound scan and assess every anatomical structure on shape changes when working your way up to the superficial image. Shape changes can occur in every kind of anatomical tissue. Examples of shape change could be anatomical tissues which get thicker, thinner, a larger or smaller cross-sectional area, changing fibre course or orientation, etc. The shape of the retinaculum on the right has changed. See the increase in thickness compared to the healthy and very thin retinaculum on the left. If the shape increases in thickness, it indicates a space-occupying process within the anatomical tissue, such as swelling, a hemorrhage, a calcification, etc. This tendon has collapsed and shows a severe concavity. Thinning is an example of a change in shape. If the shape decreases in thickness, it indicates a loss of mass within the anatomical tissue, for example due to a large tear in a tendon or muscle. The infraspinatus fibre orientation has changed in the shape in the right image, as they have a more horizontal course when compared to the diagonal fibres in the left healthy image. A change in fibre orientation, no matter which type of anatomical fibres it could be, indicates a change in relation and/or position with regards to the anatomical tissues in the direct proximity. The humeral head in the right image, for example, shows a posterior subluxation, a change in position, with, as a result, changing fibre orientation of the infraspinatus. Please note the change of shape of the tibial tuberosity bone in the right image. It's a typical sign of Osgood-Schlatter disease. Please don't forget to look for changes in lines and surfaces which are usually straight or smooth, such as bones and cartilage. Degeneration, erosions, or traumatic changes can be the cause of this kind of shape change. The echogenicity, the colour, of an anatomical structure is important. The way the grey values of the anatomical tissue looks will tell you a lot about the current state of the anatomical tissue. Describe the grey values in terms of anechoic, hypoechoic and hyperechoic. Please try to find out the reason for the echogenicity change. For example, a calcification being the cause for hyperechoity, or a muscle tear and swelling being the cause of anechoity. It's not always easy to understand the cause of the specific echogenicity. A hematoma can look the same as fluid, or a hyperechoic structure is not always a calcification. The interpretation of echogenicity changes takes time, practice, experience and good use of the technological possibilities of the ultrasound system. This is a complete tear of an Achilles tendon. Please note the anechoic zone in the middle of the image due to a fluid or hematoma. Or look at these hyperechoic zones in the deeper parts of the tendon due to many subtle intratendinous calcifications. The change in continuity of fibres is important to assess possible tears, gaps or fractures. All kinds of anatomical tissues can show changes in continuity. The muscle has been torn and retracted from the myofascial junction with the soleus muscle. The fibrillar pattern of the muscle has been disrupted, hence the change in continuity. This tendon shows a severe tear. It looks almost full thickness. Please note how the fibrillar pattern has been disrupted with only a few remaining fibres. This slide shows a scapholunate dissociation by making an ulnar deviation. The scapholunate ligament has been torn, a change in continuity, with, as a result, the increase of the joint width when stressing it. This slide shows a fracture of the patella, also an example of a change in continuity. The changes in function make all findings more or less clinically relevant. Seeing the actual anatomical tissue move or perform under ultrasound visualization is real valuable information. This part brings the clinical examination, the ultrasound examination, and the clinical reasoning together. This clip shows a retrocalcaneal bursitis during movement. Please observe the distended bursa with inside the bursa some debris. This clip shows an AC joint during movements of the arm. The AC joint should actually be very stable and show no movement. The movement we can see in this clip shows that there is a passive instability of the AC joint, and that further assessment is needed to determine the cause of the instability. For example, an injury of the coracoclavicular ligaments. Please combine as much as you can of the clinical examination with ultrasound visualization. For example, in this case, it demonstrates how to perform a stress test during scanning of the anterior talofibular ligament. The test is best carried out with the foot hanging over the edge of the examination table while pulling the forefoot anteriorly when in plantar flexion and inversion. The ultrasound images over the torn anterior talofibular ligament are obtained at rest and during maximal anterior traction. The red dashed lines demarcate the distance between the talus and the lateral malleolus. Note the opening of the joint space. After having assessed the structural changes, it's time to double check and correctly interpret them. All suspected pathologies should be scanned in two planes, both longitudinally and transversely. Scanning in two planes gives a positive confirmation that the pathology is actually present, but also gives a much better insight into the three dimensions of the pathology. The left image shows a longitudinal tendon, the right image the same tendon transverse. The tendon shows a change in shape in both planes due to thickening and a bigger cross-sectional area. Scanning in two planes gives a better understanding about the size of the length, width and height. The left image shows a transverse biceps tendon. The right image, the same tendon longitudinally. Scanning in two planes provides a better insight into how much fluid there actually is present in the biceps tendon sheath. The left image shows the width and height, thus the cross-section. The right image shows the height and length of the fluid. In many cases, it's very useful to compare the findings with the non-affected side for reference values. This is especially useful when in doubt of certain changes. Is it really a change in shape? Is it really a change in echogenicity? Or does the healthy side have the same appearance? If comparing both sides, please make use of a split screen and scan both sides in a similar way. Try to scan the exact same location. Make use of landmarks to achieve this. Please bear in mind that the other side can also display changes, especially in older people, due to degeneration, or in people with long-standing complaints in one joint because of compensatory mechanisms. The plantar fascia on the right side shows severe thickening of 8 mm of the plantar fascia at the calcaneal origin, compared to 3 mm of the healthy plantar fascia. The echogenicity of the affected side has also changed compared to the healthy side. This left-right comparison of the subscapularis shows a pathological difference indicated by the yellow arrows. Please note that the images have been made as similar as possible. Same deltoid muscle thickness, same orientation of the subscapularis tendon, same orientation and slope of the humeral cortical line, and the same lesser tubercle shape on the outer side of the scan. Images can be compared only if they are similar. Measuring your findings is not only important for diagnostics, but also for evaluating the connective tissue repair in time and evaluating the results of treatment. When measuring, try to standardise the measurements as much as possible to increase the reliability and reproducibility of measurements. The ultrasound systems offer many kinds of measurements, for example distance, volume, cross-sectional area, angles, etc. Learn how to use them in a clinical and technical way. This will have to be done through clinical experience, but also through lifelong learning, in following new courses in higher levels. The shape and dimensions of the humeroradial joint have changed. Please note the joint space widening in the right image when scanning the humeroradial joint under a varus stress. The joint space opening can be measured. This is a variable that resembles the functionality, the integrity and repair of the lateral ulnar collateral ligament. This Achilles tendon shows severe thickening, resulting in a larger cross-sectional area. Don't forget that many people have dramatic changes in anatomy, for example a complete tear of the supraspinatus, but no complaints or impairments at all. In the end, it's all about clinical relevance. Which findings are responsible for, or related to, the patient's complaints or impairments. Do your clinical examination test to decide which anatomical changes, visualised with ultrasound, are in fact clinically relevant. Please combine the findings obtained from your clinical examination with the findings of the ultrasound examination and perhaps findings of other clinimetric tools. Working like this improves evidence-based practice. More in-depth information about all pathologies, their clinical relevance and consequences for the clinical examination will be trained during Level 2, the intermediate level. Remember that there is not always an indication for doing an ultrasound examination. Indications for doing an ultrasound examination or not will also be discussed during Level 2. If you follow all the steps of the 3x4 scanning quality checklist and the 2x4 pathology recognition checklist, you can be quite certain about the quality of your findings. Nevertheless, please leave room for error when making a conclusion and stay critical towards yourself and the whole clinical situation. Before we start discussing pathology in musculoskeletal ultrasound, I would like to explain our vision on learning pathology at Level 1. The main goal of this Level 1 course is scanning three-dimensional functional anatomy. Pathology recognition is also part of the course, but a much smaller part. Before focusing on pathology, the professional should first have a good clue and knowledge of what normal anatomy is, and which normal anatomical variations there are. Only if the professional knows anatomy very well can the professional start learning pathology. The main goal of the pathology part in Level 1 is learning to work with the pathology checklist. In Level 1, the foundational level, the professional learns the basic scanning practice. In Level 2, the intermediate level, the professional learns seeing and applying it. That's the next step. The aim of the Level 2 courses is to deepen the ultrasound examination of the extremity joints, which have been discussed in the Level 1 basic course, expanded with additional positions to scan new anatomy. But, more importantly, much more focus will be put upon pathology training and pathology recognition. Pathology recognition will be placed in a larger picture of clinical examination, clinical reasoning and clinical decision making. You will note that the pathology of nearly all regions will be discussed by using the pathology checklist. The pathology checklist will be practiced over and over again. That's the main goal. The goal is not to elaborate on pathologies, as that will be saved for the next course levels. Every pathology case presented is a tool to practice the pathology checklist. An exception is the supraspinatus tendon. Since the supraspinatus tendon is one of the major indications to be scanned in clinical practice, we'll provide you with a bit more information then compared to the other regions. This extra information resembles a smaller part of the Level 2 courses.